Good afternoon all. Welcome to our presentation on advanced musculoskeletal imaging. This is Tony. He presented with a podiatrist with an ulcer on the interphalangeal joint of his hallux that was resistant to debridement and dressing. The potential underlying pathologies that were considered to have played a role in causing the ulcer include an osteophyte, osteomyelitis, and a bone tumor. Magnetic fields and radio waves capture highly detailed images of soft tissue, cartilage, and bone. It is ideal for visualizing bone and soft tissue. There is also no ionizing radiation and identifies pathology such as osteomyelitis quickly within 24 to 48 hours of infection. The disadvantages include contraindicated in people with pacemakers, metallic implants, foreign objects, and it is expensive at $285 with no Medicare rebate.
Computerized tomography uses X-rays to create cross-sectional images of the body. The good things about it are it detects bone mass and periosteal changes. It produces 3D images with high contrast and high resolution for the complex anatomy of the foot. It is also an alternative when MRI is contraindicated or unavailable. Furthermore, it identifies origins of lesions and it also identifies matrix, margins, periosteal reactions, and cortical destruction in bony lesions. The cost after a Medicare rebate ranges between $33 to $55, and the bad thing about it is that it produces ionizing radiation. Musculoskeletal ultrasounds use high-frequency sound waves to generate an image. The advantages of it are that it's inexpensive and readily available. It uses real-time imaging and can commonly be used when MRI or CT are contraindicated. It's accessible and can scan multiple joints in short periods of time. Also, it produces images of bone and soft tissue simultaneously and does not produce ionizing radiation. The disadvantages of it are that it can't produce highly detailed images of certain regions such as cortical tissue, and it's also only able to produce 2D images. Bone scans use a radioisotope to detect levels of osteoblastic activity within the skeletal system. Its advantages are that it detects the extent of skeletal system involvement in bone lesions. It's highly effective in monitoring therapeutic outcomes, and it also identifies high osteoblastic activity. Its disadvantages are that it's unable to provide clarity in complex anatomical regions such as the foot or the ankle. Also, it's difficult to determine the interosseous extent and the level of soft tissue involvement of the bone lesion. Also, it can cost between $90 to $150 after getting a Medicare rebate, and the dosage of 5.1 millisieverts is significantly high compared to a CT scan of the ankle or the foot. Furthermore, it commonly requires additional imaging such as CT scans, MRIs, or X-rays for the confirmation of a diagnosis.
Osteomyelitis is an inflammatory process of the bone and marrow by infection. Ulcers can expose bone tissue to potential pathogens causing infection, and inflammatory responses such as this result in significant complications such as amputations if not diagnosed and treated early. According to the literature, MRI was found to be the most favourable imaging technique for detecting osteomyelitis, with high sensitivity and specificity rates of 90% and 79% respectively. They produce finely detailed images of osseous and soft tissue, and they are the standard imaging for osteomyelitis. The sensitivity and specificity of CT has been found to be 67 and 50%. However, this has not been clearly established, as it has also been as low as 24 and 3%. CT is beneficial as it can identify changes in bone mass, soft tissue, and periosteal reactions. It provides high contrast and resolutions in its images and is a standard form of imaging when MRI is not available. Ultrasound is the next most desirable form of imaging as it is capable of differentiating infections and tumours. It is less expensive and more accessible than CT and MRI and provides no ionizing radiation. Tony's other suspected pathology was a bone tumour. A bone tumour is a neoplastic growth of bone tissue that is either benign or malignant. In regards to Tony, a primary tumour originates in the problematic bone, while secondary tumours are metastases from other regions of the body. The extra osseous growth associated with the tumour may increase pressure on the underlying tissue, leading to ischemia and trauma, actions which may allow an ulcer to develop. CT is recommended for bone tumours with a sensitivity of 90% and specificity of 96%. It is also capable of distinguishing between malignant and benign tumours by imaging the margin, cortical destruction, and involvement of the internal matrix. This allows CT to characterise the bone matrix mineralisation for differential diagnosis. MRI is the next best option as it is highly sensitive, detects soft tissue involvement of the tumour. It also emits no ionizing radiation. Ultrasound sensitivity is primarily reliant on the tumour location, and it can only image tumours that breach cortical bone with extra osseous or periosteal mass. The final suspected pathology for Tony was an osteophyte, which is a bony outgrowth of calcium deposition along a joint line. The pressure caused by the osteophyte on the surrounding tissue can produce ischemia and trauma, potentially resulting in ulceration. CT is highly sensitive at 100% with a specificity of 87.5%, providing multiplanar images that give an accurate depiction of bone. Ultrasound is the next best technique with sensitivities and specificities of 83 and 97.5%. It can scan multiple joints quickly, it's accessible and doesn't produce ionizing radiation. MRI is less sensitive and specific at 50 and 71%. It also produces multiplanar images and visualizes multiple tissue pathologies without ionizing radiation.
Our algorithm relies mainly on the MRI availability. If it is available, we would use this to potentially avoid any exposure to ionizing radiation. However, if MRI isn't available, we would have to use the next available high-quality imaging technique. Bone scintigraphy, or bone scan, would not be used due to its high levels of ionizing radiation, much greater than that of a CT scan of the foot. It is also unable to produce high clarity of the complex anatomy of the foot. Therefore, we are unable to determine the proximal spread of infection if osteomyelitis was present. The presence of trauma, degenerative joint disease, surgery, as well as implants can reduce the specificity down to 10%. Because of this, it would require further imaging to confirm diagnosis. We would either use CT or MRI to confirm with this. However, this would increase the potential exposure of ionizing radiation, as well as increased costs towards Tony's diagnosis. If MRI is not available, we would look at CT, as it is the preferred imaging for osteophytes and bone tumours due to its high sensitivity and specificity. It is also the recommended imaging technique when MRI is not available. If MRI is available, we would start off with using ultrasound, as it can differentiate between tumour and infection. It's also quite sensitive and specific to osteophyte diagnosis, as well as that it is also commonly used to diagnose osteomyelitis when MRI and CT is contraindicated. If ultrasound was able to identify an infection, we would then use MRI, as this has no ionizing radiation and in conjunction with ultrasound is a good combination. It is also the standard imaging for osteomyelitis due to its sensitivity and specificity. It's also quite sensitive and specific for bone tumours. It is less sensitive and specific for osteophytes, however, the use of ultrasound can compensate for this. If MRI was contraindicated by foreign or metallic implants, we would then decide to use CT or ultrasound. If a tumour was found, we would use CT first, as it is sensitive and specific for bone tumours and also provides high resolution and clarity of the anatomy. If CT, though, was contraindicated due to the levels of ionizing radiation, we would then use techniques that don't have any radiation, such as MRI and ultrasound.
In terms of the appraisal of evidence, the criteria used was the NHMRC evidence hierarchy. According to this hierarchy for diagnostic accuracy, Level 1 evidence would be systematic review of Level 2 studies. For the evidence found for osteomyelitis, we found a systematic review of Level 3 studies, which assessed the accuracy of diagnostic imaging modalities for chronic osteomyelitis. Unfortunately, the remainder of the articles were literature reviews written by experts in the field. For the evidence of osteophytes, most of the literature available were expert opinions and literature reviews. No systematic reviews or studies that rank highly on the NHMRC criteria were found. For the evidence of bone tumours, the highest level of evidence that was found was ranked as a Level 2 study on the NHMRC criteria. This study investigated the value of CT images interpretation in the differential diagnosis of benign versus malignant primary bone lesions. The remainder of the searches principally resulted in studies that were outdated, ranging from 1977 to 1999, which is why this literature was not used. More recent literature, however, was found in the form of books, literature reviews, and expert opinions. In terms of search strategy, we used a number of databases. The ones used for bone tumours included ScienceDirect, Sentinel, and LibSearch. Examples of the keywords include bone scan, bone tumour, bone scintigraphy, as well as bone scan sensitivity and bone scan safety. For the search for osteomyelitis, the databases that were used included ScienceDirect, PubMed, Medline, and LibSearch. Once again, the keywords used were osteomyelitis, imaging, bone infection and imaging, computed tomography or CT, bone scintigraphy, osteomyelitis, and MRI. For osteophytes, the databases used included PubMed and Medline. The keywords used included radiation exposure, musculoskeletal or computed tomography, osteophytes, ankle imaging modalities, and USG.
Thank you! Woo! Well done! Yeah, I like this song. Dun, 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 dun.